prostate cancer treatment, Dr. Burnett.
Well, good morning, everyone. First, I want to thank you, Dr. Kennard, for those very kind remarks. And I've been at Hopkins 30 years, so that's why I've been able to do all these things. I certainly want to thank Dr. Farrington and thank you, all the organizers, for inviting me to speak. And certainly, I'm honored to be here. You know, certainly, I'm inspired by all of the survivors, all of those that I've cared for. You know, many times it looks as though, as surgeons, it's a one-way street. You know, we deliver service and we at least have the sense that the patient's the one who's gratified and gains from that interaction. I have to tell you, it's bidirectional. And I'm always inspired by my patients. That certainly inspires me to be so committed to this disease state and to continue to make progress where we can. Bring my best abilities to the care of the patient, to make innovations and help advance the field. Now, we've had a wonderful presentation already this morning, and I'm going to speak about PSA testing and the conundrum there. I thank the presenters already. I've learned a lot. I hope you have. I'm going to speak here now about another subject that also invites a lot of controversy. Now, sexual aspects relating to prostate cancer is not really new, and I think, of course, you already heard about how men in general, including African American men, dread the finger. They certainly dread anything that would affect their sexual function. So much so that many men do not want to pursue any kind of evaluation down there, pursue any kind of intervention that may in any way affect their sexual function. You know, as a practicing urologist, we see this all the time. You know, and I certainly sense from many patients that they do struggle with this. I have patients of mine who've said, well, Dr. Burnett, I'm not sure I want to proceed with any therapy because this may affect my sexual function. But of course, I've had a patient who's told me that after thinking about all of his options, he realized that the ultimate form of erectile dysfunction is death. And so he better move forward definitively with addressing the problem. So maybe that's one way to put it all into perspective and to consider that we should understand the problem, address it head on, become informed, and then try to decide what is the right decision to make. I think that's what we're doing today. I think we're trying to be more informed. We're trying to make the right decision. We're going to be informed about our testing, be informed about how we go about treatment, try to understand what our risks are. Should we go forward with treatment, balance the harms and the benefits, but make the right decision. And certainly if we ignore the problem, then we may experience the worst outcome, which is the ultimate form of erectile dysfunction or sexual dysfunction, and we want to avoid that, of course. So my topic, of course, is addressing prostate cancer sexual issues. I've been given the charge to speak to that, and I'm delighted to give you some information about that, tell you where we are and where we're advancing. Next slide, please. So by way of objectives, I'm going to speak about describing the various ways prostate cancer management can potentially affect sexual function. But more than that, how are we addressing this? And what are some of our current management strategies? And where are we going in this field to address these concerns? Next slide, please. Now, sexual dysfunctions in men are complicated. Some would say they're complicated in women, but they're complicated in men as well. And there are many aspects to this, and this slide just makes the point that it's not just all a matter of erections. Many men are concerned about various aspects of their sexual function, and I think rightly so. Not just a matter of getting erections, but sexual desire issues, ejaculatory function. All of these aspects are relevant, and we understand this better and better. I think we've discredited, as urologists, our field and others by just using generic terms, you know, manhood or, my macho and this and that, and then, we use the word impotence. Impotence, I think, has been this kind of a broad stated term that really is not very specific. It also has this kind of a demeaning tone to it. I think we use the word now erectile dysfunction when we're talking specifically about the inability to attain and maintain erections used for sexual intercourse. But there's other aspects of sexual function, as I mentioned, ejaculatory issues, sexual desire issues, and this just makes the point that we want to address all of this, including relationship issues. And I think all of this is relevant, and we shouldn't just simplify it in men or women with regard to sexual dysfunctions. Next slide. Now, let me just make some facts, tell you some facts about the erectile dysfunction. We'll start there. You know, you heard facts this morning, and I think it's always important to get the facts. I think we're informed, you know, we make better decisions, and then we actually can handle what kind of decisions we have to deal with when we're faced with issues. Well, we know that, speaking to surgery now, we know that it has excellent long-term rates of success. We've actually have seen that this has evolved. I won't give you a lot of statistics, but I think this is true. We've evolved to this stage. We know that erectile dysfunction has been a long-standing complication of the condition, so much so, as I mentioned, that many men were discouraged to consider any form of treatment, whether it's surgery, radiation, or other forms of treatment. It just so happens that the reality is the prostate's in a very precarious part of the body. It's located deep in the pelvis, where a lot of stuff is going on. You know, nerves that have to do with erection, blood vessels that have to do with erection, adjacent to our sphincter mechanisms that have to do with urinary control and bowel function. So it's just a very precarious part of the body. And so therefore has been challenging for many, many years. We have advanced the field with the innovation of what we call nerve-sparing radical prostatectomy. Many of you have heard about that. And that was pioneered by Dr. Walsh and others. I think others have also made some observations, but certainly Dr. Walsh is credited. He's my mentor and was the chair of the Department of Urology at Hopkins for many years, 30 years. And he now is more or less a professor emeritus there. But you know, he made some salient observations that the nerves don't run right through the prostate, they really run around the prostate. And if we can actually do the surgery better, we can deliver better outcomes. And I think that's been observed. And now the literature will have all kinds of rates from different institutions about the success that may vary here and there. But I think there's no argument that understanding the surgery better, performing it better, has led to better outcomes. Many men can recover their sexual function, particularly with regard to erections. And I mentioned the nerves and the blood vessels that surround the prostate that we preserve while doing the surgery without compromising cancer control. And if the surgery is done very well, the very best outcomes can be achieved. But I think it's important to know that we don't do nerve sparing all the time. Why? If we think the cancer is locally spread, we do have to go a little bit more broadly surrounding the prostate to get all the cancer, and that may compromise a man's function. Again, intelligent surgery, doing the surgery well. And we do know that many men will recover erections, although the nerves, even with nerve sparing, can be traumatized and they get shocky. And it may take as much as a year, year and a half, maybe 2 years to fully recover erections just because these nerves are kind of in a state of shock and they have to recover. We use these fancy medical terms, neuropraxia and things of that sort. But know that you know, many men can recover function with appropriately assigned surgeries. And we're still wrestling with this issue. How can we allow men to recover their erections better and faster, even with nerve sparing? And the challenge is even greater these days. I've been doing this surgery for 25 years. And I can tell you, you know, it used to be that men would undergo the surgery. It'd be a 4 or 5 hour operation. They'd be in the hospital for several days. They'd go home. It'd take a year to recover. The urinary control would take a long time, sexual function a long time. Even just resuming normal activities would take a long time. Nowadays, we do the surgeries very proficiently in about an hour and a half to hour and 45 minutes. We're very good at how this surgery gets done. Many patients will be in the hospital a day or two, go home looking very good, almost as good as I am walking around right now, have a catheter for 10 days or so and get that out. And they actually recover their functions in terms of their occupational, other recreational activities fairly soon, get their urinary control back really within a few months, even sooner many times, not a whole year. But sexual function, these nerves still being traumatized may take a long time to recover. And so therefore we still have, I consider almost the last frontier in addressing the surgery. How can we allow men to get all their functions back faster? And that's really where I'm dedicating a lot of my efforts as a researcher in my laboratory to understand what goes on with these nerves and how we can make them function better. So we're working on these sorts of things. But this is the reality of things. Men have done better than in the past, and we're still working to make progress. Now, this is not an issue just related to surgery alone. You know, there are complications related to the other forms of intervention as well for localized disease, such as radiation, whether it is external beam radiation or the seed technique or brachytherapy. Again, the prostate's in a very precarious place. And so it has to be stated that it's not just an issue of surgery, it's an issue with any intervention. And we're understanding the physiology and that is the functional status and the pathophysiology, that is how these things go awry and how we can make them better. So no, we're dedicated to making progress. Next slide. Now, there are many mechanisms for erection loss after radical prostatectomy, or for that matter, any intervention. And this slide just makes the point that there are issues that relate to how surgeons do the surgery well, nerve sparing when it's appropriate, preserving the nerves, the vasculature, the blood supply that also feeds the root of the penis. But there are also, as you can see on the slide, other factors there that do have impact with regard to a man recovering function. I can do the very best surgery I can do, but if you go out and keep smoking 3 packs a day and eating McDonald's every day, I can guarantee you that no matter how much nerve sparing I'm doing, you're damaging your structures in the pelvis. So I think men have to realize, and the families need to realize, you need to be healthful yourself. And I always counsel my patients that you got to be fit, you got to try to be fit, and you got to try and do the right things to try and recover your best recovery. Because there are other factors, including people's histories of comorbidities, the other factors you can see on the slide that do impact on sexual function. It's not all just us here. It's got to be a kind of a team effort to recover your best function. Next slide. Now, this just makes a point that this is where we are currently in the field with conventional therapies for managing erectile dysfunction. We use this process of care model that has first line, second line, third line domains, if you will. This is pretty much along the schema of least invasive to most invasive. We always try to do conservative things first. Obviously, pills are fairly non-invasive there. I mean, they're oral and they don't really have potentially a lot of immediate effects to the body as much as injecting medications with needles in the penis, which I don't think any man is too fond of, or using an external vacuum pump, which is a bit intrusive as well. Those are second line options. These things are very effective, but if we can get a man to respond to first-line therapy, such as oral medications, the medications like Viagra, Levitra, Cialis, you may have heard these medications. Of course, everybody should have, I guess, if you're been around here for the past several years. So these medications can be effective. They may have their best effect, though, when you have at least partial erections or more, to which they augment the response. And early on, following radical prostatectomy, many men may not necessarily respond to these medications, understandably, because of just how these medications work. The pharmacology of these drugs are that they work through mechanisms that require some integrity of function to which they augment effects. Second line options many times are explored in the interim of time following surgery, even time after radiation. These things may be offered sometimes temporarily. The beauty of second line treatment options, even though they are intrusive and semi-invasive, is that they are reversible, meaning that if you start to recover function, you can put them down. You haven't done anything irreparable or irrevocable. Penile surgery, penile prosthesis surgery, which is the third line option, putting in a penile prosthetic device, many times men do opt for. Maybe they have more significant disease and it's very unlikely they're going to recover their function because we've had to go more broadly in the pelvis with surgery. And it's really inevitable that they're not going to really recover their very best function. Some men feel that they don't want to explore the second line options. They're just not for them. They're not really spontaneous enough. Maybe they're a little bit too intrusive to be doing every time that they want to proceed with sexual activity. So penile prosthesis surgery is still done. I do a lot of those surgeries as well. And that's a device put inside the penis. It works very well. It allows men to be very functional. It provides a mechanism for penile rigidity. But every aspect about the penis and sexual function is still intact in terms of sensations in the penile area, the ability to have stimulation and achieve an orgasm. All these sorts of functions are entirely intact. So, and nothing is sticking outside the body. You look as normal as anybody. So these are devices put inside the body, and they can achieve an ability to resume one's intimacy with their partner, and that can be fine. So these are our current options that are available. Conventional therapies. We typically hold off, as I said, on a penile prosthesis surgery if we have some expectation that that man may recover function following the surgery. Now, maybe after enough time goes by, that could be as much as 2 years, and if that man has heard his options and he has not had nerve-sparing surgery and he's not really recovering, this may indeed be an option he may want to consider. And I want men to hear that because I think oftentimes you hear about penile prosthesis surgery getting a bad rap, that it can have a lot of complications. These surgeries done by very proficient surgeons can be done very well with high success rates. And so I think it's important to make that point. Next slide. Now this slide just makes the point here that in this current era of time, we're recognizing that there is an approach to addressing sexual function and erectile dysfunction in particular following interventions for prostate cancer with this concept of rehabilitation. I don't know how many of you may have heard this. Penile rehabilitation, erection rehabilitation. You know, it's a strategy that we've coined in the field to say we're trying to help men see whether we can strategize with various techniques or approaches that may help them recover their erections better and faster than just treating them with conventional therapies, which is the first bullet, and just hoping that they'll recover their function. So these rehabilitation strategies may involve conventional therapies that we currently have, as you saw from the prior slide, but they may also involve some novel things that we're working on that we think may allow us to help men get that function back faster. You heard me comment on really with the frontier of trying to get guys to recover better, even with nerve sparing, even in this era of nerve sparing surgery. We're working on this. Now, the most common thing you may have heard of is taking a Viagra or one of the other pills daily after prostate surgery or daily after radiation. How well does that work? That's always a question. And the answer is that while we've had some well-meaning studies done, intentions to bring back therapy bring back responses using this therapy, the current results are very equivocal as to whether using this sort of intervention can work like a vitamin and help your erections come back faster. And so I think this is something that has to be individualized. I talk to every patient about how these therapies can be used, although we're uncertain about how successful they will bring back function. They can be costly. These pills are not inexpensive. And so I think we have to continue to have this dialogue about where we are in this field with therapies we currently have that may not be necessarily well proved to be effective, while we also continue to innovate, do research, and think about new therapies. And of course, one strategy I always tell patients is, in this era, and in this setting here, of course, your very best health, and then doing your very best to recover your fitness and staying well is also a strategy behind rehabilitation. Next slide. Now, I'm going to change subject for a moment and just talk about some other aspects of sexual dysfunction that occur with the management of prostate cancer. Hypoactive sexual desire, and you can just briefly read from the slide as I'm talking, refers to the changes a man may have with regard to interest in sexual activity, his libido. This may arise in various settings surrounding prostate cancer management. Of course, if your sexual function changes, you may have less of an interest to want to pursue sexual activity, and that's completely understandable. It can also occur in the setting of various hormone deprivation therapies that we use, either in combination with some of the local therapies such as radiation, or for men with more advanced disease, we use hormone blockers. You may have heard of that, and many men have heard about these kinds of things. We call that androgen deprivation therapy or hormone suppression therapy. All these are terms that are used. And blocking a man's hormones, as you might imagine, can change his libido, can change various functions of the body, in addition to various potential side effects as well. And we know that hormone deprivation can cause all kinds of effects with regard to not just your sexual function, but changes in your body composition, maybe even changes in cognitive function as well. So these things are very serious and need to be discussed when considering any kind of hormone suppression therapy. But with regard to sexual dysfunction, it can have impact, and I think that we have to recognize that has to be discussed, and I think that we have to talk about how we can address this problem, be very careful about getting men on this kind of therapy, and there's various strategies to be considered there. And along the way now, we do recognize that there may be other aspects of that man having changes in his libido, his sex drive, just the depression of having had a major cancer. Undergoing some sort of treatment for that, and sometimes just having sessions with your physicians, with other mental health care advisors, always can be very, very important in trying to address all of these issues. Next slide. This just makes a point here about androgen replacement therapy that we do use in the field, giving hormones back to men. This is a very controversial area in our field as well. In men who've had prostate cancer, because prostate cancer, you just heard, is hormonally driven, like breast cancer, the male hormones for prostate cancer is the fuel to these cells. So there's always this dilemma that occurs in men who may have either been treated or even have prostate cancer that we know of. Can we safely administer testosterone replacement therapy? So this is actually great media attention. I think you may have heard just in the media, there's a lot of kind of a firestorm surrounding all of these issues. And I think this is, in the field currently, is a matter of great debate. And I think this has to be individualized. We have to understand that man's profile of disease and the safety of considering hormone therapy and what are the potential benefits and harms and how well we think that giving hormones in the setting of a man who's been successfully treated for prostate cancer but may still have some indolent or occult disease somewhere in the body, or men who actually already have the diagnosis and we're just you've heard about active surveillance. This is a great dilemma. Men that we have prostate cancer, we know have prostate cancer, can we safely give them hormone treatments to help their libido, testosterone replacement, while they have prostate cancer? And so this whole area is not resolved, and I think this has to be individualized, and patients need to understand the real risks and benefits in their case and how they need to be monitored if they elect to go on testosterone therapy. This may invite more discussion later, but I'm just telling you that we don't have the answer, but I think we have to make sure that we discuss this thoroughly. Next slide. Now, ejaculatory and orgasmic dysfunction is important to briefly spend a few minutes on. In men who undergo radical prostatectomies and men who undergo radiation, your ejaculatory function will change. The structures that are responsible for fluid emission and what's a part of the ejaculatory effect is the fluid from the prostate and the seminal vesicles, structures that are removed with surgery and are also changed with radiation. The prostate will involute, shrink down, and the amount of fluid that's produced in the prostate with radiation will affect your ejaculatory response as well. Men can still have orgasmic sensations, okay, but the fluid that comes out is not going to be there. In addition now, in some men with treatment, their ejaculatory or at least their orgasmic effects may be the same, but some may be heightened, some may be worsened just by the impact of treatment in the prostate area. And this may have to do with surrounding structures in the area of the ejaculatory response, and I won't get all the details of the science of all that, but this can be impacted. And one of the things that we also observe in men who've undergone prostate surgery is this issue of climacteria. So a lot of men talk about this, and I think it's worthwhile just making a comment. What that refers to is the release of urine with sexual excitement or having an orgasm, and it's very troubling that some urine comes out. This is called climacteria. It's a well-known entity. We do see it. We do have to recognize that this is a problem, and it's addressed in various ways. Why it happens is because with removing the prostate, some of the structures there don't clamp down quite so well as with a normal man. You have your ejaculation, but no urine comes out, but the sphincter zone and all of that change does predispose you to having this climacteria effect. So we have to address this urinary incontinence that occurs in this setting in men. Sometimes we have some drugs we can try, so there's various agents that may tighten the sphincter zone. And others we may have to talk about just some behavioral strategies before you engage in sexual activity. Go empty your bladder, let's see whether that may help. And others we may have to go a step further and consider various interventions that maybe even be surgical in some instances. And we have some options to address with men with incontinence, independent of sexual issues, but some may have very severe climacteria, and we may have to address that surgically as well. Next slide. A moment to speak about relationship issues. This just makes the point that I think many of us are in the field here hopefully are recognizing more and more that the sexual dysfunction that can occur in the setting of prostate cancer management it has impact to the couple. And it's not just something that affects just that man alone. It really affects the couple. We should address this. We should recognize this. Many times I invite my patients to bring their spouse or their partner in for a discussion. And then let's talk about where the problems arise. Sometimes there's issues where the partner may say, like, I don't want to pursue any sexual activity. And maybe there's been changes in their life that they feel that is not important. So there you can see there's a lot of dynamics there. And I do think that that's something that can be discussed, should be discussed. We should give attention to that and be forthright about it. And if necessary, bring in other specialists that can help us discuss the problem and address it. And I do have some other colleagues in mental health that I do work with. But I do think that this is something that from the professional side, I think we're trying to be a bit more earnest about this and know that we should be receptive to these kinds of concerns as they arise. Next slide. This is, I've been trying to keep this kind of a non-medical talk, but I'm going to throw in one kind of a clinical study. Just this makes the point here that we do recognize how important sexual counseling has in the setting of prostate cancer surgery, as much as it would be, again, for any intervention, including radiation for prostate cancer. And this is just a study that shows you sexual counseling, SC, has better outcomes than just doing injections alone in terms of various endpoints of better satisfaction scores, less dropouts, maybe even eventual responses to sildenafil, one of the oral pills. In managing men with having prostate cancer treatment, it is our responsibility to coach our patients, to support our patients, to be there for our patients and help guide them. This may occur along the lines of some formal sexual counseling, but I think that really the strategy of rehabilitation should begin with being a partner and having an alliance with our patients and trying to help them understand, be educated about their recovery, know what their options are, and try to help advance them along. And I think that's key. And this study just makes that point, that that's how we make success and help recover a man's sexual function. It begins with being a partner with our patients. Next slide. So I'm going to conclude there with some final remarks that sexual dysfunctions are common complications and there are risks of prostate cancer management of various forms, including surgery, radiation, as well as hormone deprivation and any other intervention. This has to do with the precariousness of the anatomy of the prostate, but also the fact that the interventions we administer can have some negative impact on sexual function. Sexual dysfunction problems should be recognized and appropriately addressed. I think we're giving more and more attention to this, thank heavens, and I think we can address this better for our patients. And there are a variety of interventions that exist. These can be tailored and they can be implemented and individualized based on the goals of the patient. We are making progress in the field with conventional therapies as well as innovations. Scientifically, hopefully we'll continue to make more advances and expect men to recover their functions better after treatment. So I will stop there, and I do appreciate your attention. I'll gladly field questions. Again, thank you.